Welcome to the next session of the ART and pregnancy section, case-based discussion. My name is Associate Professor Tavitiya Sudjaritruk, who will be presenter of the case today and discuss the case together with Associate Professor Thailand. So let's begin our case. This is a 24-year-old woman with perinatally acquired HIV infection. At the age of 12 years, she was started with combination antiretroviral treatment with sadovudine, lamivudine, and efavirenz. And at the age of 20 years, she was switched to TDF or tenofovir, lamivudine, and ritonavir boosted atazanavir due to the virologic failure. And at the age of 21 years, she lost to follow-up from our HIV clinic. And this is a summary of her treatment history. You can see that at the age of 12 years, she was started her first line antiretroviral treatment with sadovudine, lamivudine, and efavirenz. And about 5 months later, her viral load declined to undetectable level with this regimen. And at the age of 17 years, her viral load still undetectable, but she was switched to the single dose daily regimen, which is TDF, lamivudine, and efavirenz. At the age of 20 years, her virus rebound to about 44,000 copies per ml. So she was switched to the TDF, lamivudine, and ritonavir boosted atazanavir. And at the age of 21 years, her virus declined to about 15,000 copies per ml with this regimen. But after that, she was lost to follow-up from our HIV clinic, and her combination antiretroviral treatment was discontinued for about 4 years. Earlier this year, she came back to our HIV clinic on March 2020. And at that time, she was pregnant with a gestational age of 20 weeks. Her CD4 cell count was about 48 cells per cubic millimeters without any clinical or opportunistic infection. And the HIV of her partner was still negative, but she has not yet disclosed her HIV status to her partner. Her serology of hepatitis B, hepatitis C, and syphilis were all negative at that time. For question number 1, which I would like to ask Dr. Thanavi to address this question, is that what is the most appropriate CAR regimen to restart in these pregnant women? Dr. Thanavi, please.
In this case, pregnant woman already on ART and has ARV interruption. So issue to be considered is that at the time of ART interruption, are there any drug-resistant mutation? But in this case, she stopped treatment on boosted PI, which have high genetic barriers. So I don't think that they will have a high risk of HIV drug resistant. But the question is more on pick the regimen that have rapid viral suppression, because now she is gestational age of 20 weeks. So she has time to start ART for only about 16 weeks. And issues of tolerability, because she has experience of ARV interruption. So we would like to choose the regimen that has highest tolerability, low side effect, and also easiest to use. So in this case, I prefer boosted PI. I prefer integrase inhibitor over boosted PI, because boosted PI has higher GI side effect. And also in terms of the low adverse events, TAF or TDF also have low adverse pregnant outcome. So in terms of regimen of choice, because in Thailand we not have access to TAF yet, so I choose between TDF, FTC, DTG, or TLD. So in this case, I decide to choose TLD, tenofovir, lamivudine, dolutegravir once a day. So in terms of Dolutegravir PK in pregnancy, dolutegravir we should recommend to eat with food during pregnancy. And in terms of pharmacokinetics, data from PANA study showing that DTG is a highly protein-bound drug. So the protein unbound concentration is the one that is related to clinical efficacy and biological efficacy. So in pregnancy, the data showing that minimum concentration of unbound DTG is higher than IC50, more than 93%. And also it have high cord blood, maternal blood ratio, means that when mother take this medicine, it's already transferred to fetus. So it's benefit in terms of neonatal pre-exposure prophylaxis. So Dolutegravir PK is supportive to use in third trimester pregnant women. So in this case, after start treatment with tenofovir 3-TC dolutegravir. The next question is when to monitoring plasma viral load, and also what is the neural tube defect risk in this baby. So in terms of neural tube defect, this one is have less concern because it's already in the second trimester, because data of neural tube defect showing that if we start treatment in first trimester or at conception, data from Botswana and Brazil showing that from birth surveillance study in Botswana showing that the risk of neural tube defect is 3 over 1,000 live births. In Brazil, is no neural tube defect from 382 pregnant women. So it's showing that in this case, the timing of organogenesis is already passed, so the risk is not high. But what is the background rate of neural tube defect is depend on countries. This one cannot generalizability from US. For example, in Africa, when folic acid was not fortified in food, the risk of background rate is 0.12, and in US is 0.06%. So this one, I would answer that the risk is not higher than in general population because the organogenesis is already passed. So the next question is when to monitor viral load. This one is important because usually in adult taking ART, you would wait until 6 months after treatment to monitor viral load. But in pregnant women, we would like to document that the patients had viral suppression in order to quantify the risk of HIV risk acquisition in neonates, and also to plan for mode of delivery. So for integrase inhibitors, by 12 weeks of treatment, more than 90% should have viral suppression. So in this case, I think that we should monitor treatment outcome by 12 weeks of ART. Next, please. Yeah, so in this case, you can see that within 12 weeks, the viral load becomes undetectable and CD4 improved to 132. So the next question is that, what should we plan for mode of delivery? Dr. Tavitiya will help us to plan on management during delivery and also neonatal management.
In order to address this question, I would like to update you about the current American College of OB/GYN recommendations on the mode of delivery for pregnant women living with HIV. For pregnant women with a plasma HV-RNA level equals or less than 1,000 copies per ml, vaginal delivery is recommended because the risk of perinatal transmission of HIV is quite low. The cesarean section delivery is not recommended unless there is an obstetrical indication for C-section. For the pregnant women with plasma HV-RNA greater than 1,000 copies per ml, in this case, scheduled cesarean delivery at GA 38 week is recommended because we would like to minimize the risk of perinatal transmission of HIV. And why the GA 38 week is recommended for C-section is that because we would like to ensure that the delivery happened before the spontaneous labor and spontaneous rupture of membrane. For the case that pregnant women with unknown HIV levels near the time of delivery, they recommended that we should manage similar to that of pregnant women with plasma HV-RNA levels greater than 1,000, which means that we should schedule cesarean section at delivery at the gestational age of 38 weeks, irrespective of administration of antepartum antiretroviral treatment. So why we use the cutoff of 1,000 to determine the mode of delivery for pregnant women living with HIV because of the result of this study, which was published in New England Journal 1999. And you can see that in this table, the rate of perinatal HIV transmission from mother to baby depends on the maternal plasma HV-RNA levels during pregnancy. And you can see from this table that if maternal plasma HV-RNA less than 1,000 copies per ml during pregnancy, the rate of HIV transmission to her baby is just 0%. But will be increased to 17 to 41% if the plasma viral load of the mother during pregnancy greater than 1,000. So for the next question, for this question is, I would like to answer that vaginal delivery is the most appropriate for this case because these pregnant women or our case have viral suppression nearly delivery. So for the baby history, she was born on July 3rd, 2020 at the gestational age of 38 weeks with normal delivery, and her birth weight was 2,470 grams. So for the next question is that, what is the risk of HIV acquisition during pregnancy? That means the risk of HIV acquisition during antepartum and interpartum in this baby. So I would like to briefly review that HIV acquisition during pregnancy can happen during antepartum period or interpartum period as well as postnatal periods. So the strategy to reduce the mother-to-child transmission of HIV can be implemented during the antepartum, interpartum, as well as postnatal period. For antepartum period, we should start antiretroviral treatment as soon as possible to pregnant women, regardless of her CD4 cell count and plasma HIV RNA levels, in order to decrease the maternal HIV RNA in her blood and genital secretions and achieve antiretroviral drug levels crossing the placenta and to produce adequate systemic drug levels in the fetus. For the implementation that we can implement during interpartum period include that we should ensure adequate antiretroviral drug levels during labor and delivery by continued current ARV regimen in the pregnant women and intravenous sedalvidin during labor if indicated, such as if the viral load in mother during third trimester greater than 1,000 copies per mil, avoid prolonged labor and prolonged rupture of membrane, avoid unnecessary trauma during delivery, and set elective cesarean section if indicated, such as the maternal viral load greater than 1,000 during third trimester. For the intervention that we can be implemented during the postnatal period include provide infant prophylaxis. That means we administer antiretroviral drugs to the infant as soon as possible after birth to provide protection from cell-free and cell-associated virus that may have entered infant systemic circulation during labor and delivery. And according to the local and national guidelines, some countries recommend that infants should avoid breastfeeding, but some countries recommended that infants should receive exclusive breastfeeding. So because our pregnant women or our case received dolutegravir base during third trimester of pregnancy, so I would like to show you the result from this study which just published in Journal of Acquired Immune Deficiency Syndrome 2020 a few months ago to see the mother-to-child transmission rate of HIV within utero compared between mother received dolutegravir base and efavirenz base in Botswana. And you can see from this figure that among the pregnant women who received dolutegravir-based and efavirenz-based regimen during pregnancy, less than 1% of them had transmit her HIV to her baby, 0.6 among those received dolutegravir-based, and 0.4 among those received efavirenz-based, compared to 4.4 if the mother do not receive any ART during pregnancy. And when we look in the detail of this regimen, if dolutegravir started before pregnancy, the rate of HIV transmission from mother to child was just 0%. But if dolutegravir started during pregnancy, the rate of HIV transmission was about 0.8%. For among those received efavirenz-based regimen, if efavirenz start before pregnancy, the rate of HIV transmission to baby was 0.07%, and if efavirenz-based start during pregnancy, the rate of transmission increased to just 0.9%. And in this study, the most of the mother-to-child transmission events occur when antiretroviral treatment was started less than 90 days before delivery. And this study also shows you the result and the information about the safety and pharmacokinetics of dolutegravir in pregnant mothers as well as her baby from a randomized trial Dolphin-1 study. And you can see from this table that for the PK endpoint, which is the primary endpoint of this study, you can see that dolutegravir was very well transferred across the placenta. The level in the placenta was about 121% compared to plasma concentrations, and very well excreted into breast milk, 3% of plasma concentration, and coupled with slow elimination. So this led to the significant infant plasma exposure of about 3 to 8% of maternal exposures. Also, for the viral suppression endpoint, which is a secondary endpoint of this study, you can see that the proportion of undetectable viral load in the pregnant women was significantly higher among those received dolutegravir-based CAR regimen compared to the efavirenz-based regimen. And you can see from this Kaplan-Meier curve that the probability of virus not suppressed was significantly higher among those received efavirenz-based regimen when compared to dolutegravir-based regimen. And also, dolutegravir resulted in significantly faster virus suppression at 2 weeks postpartum visit, with a median time to virus undetectable of 32 days compared to 72 days among those received efavirenz-based regimen. So for this question, I would like to answer that the risk of HIV acquisition during pregnancy for this baby was less than 1%. And for the neonatal management in this case, this baby was classified as low risk for HIV acquisition. So according to Thai guidelines, we provide infant formula and avoid breastfeeding for this baby and provide her as soon as at birth of BCG and hepatitis B vaccines. So for the last question for this case is that, what is the appropriate infant prophylaxis for this baby? I would like to say that the recommendation on infant prophylaxis is quite varied across the guidelines. And this table, I try to summarize the recommendation of some main guidelines. And you can see from this table that if we classify the infant based on the risk of perinatal HIV transmission to low risk and high risk, and this is the guidelines. For the low-risk infant, the HHS guideline or US guideline recommend to use Tadalvidin for 4 weeks, which are very similar to Thai guidelines. And for the WHO, they recommend to use nevirapine for 6 weeks for those infants who were breastfed, and Tadalvidin or nevirapine for 4 to 6 weeks for infants with receiving replacement feeding. For the British HIV Association guidelines, they recommend to use Tadalvidin for 2 to 4 weeks. But for Swiss guideline, they did not recommend to use any infant prophylaxis because they believe in the concept of U is equal use or undetectable equals untransmittable. For high-risk infant, the DHHS guideline recommend to use triple therapy of Tadalvidin, lamivudine, and nevirapine or dolutegravir for 6 weeks. For the WHO, they recommend to use the dual therapy of Tadalvidin and nevirapine for 12 weeks for those breastfed, or for 6 weeks for those receiving replacement feeding. For BIWA or British guidelines, they recommend to use triple therapy of Tadalvidin, lamivudine, and nevirapine for 4 weeks, which was very similar to Thai guidelines. And for Swiss guidelines, they recommend to use triple therapy of Tadalvidin, lamivudine, and nevirapine during the first week of life, and then consult a PhD specialist for further management. So for this case, for our case, you can see from the last slide that choice A, B, and C are all correct. But the choice D is incorrect because this is the regimen that we recommend to use for high-risk infant instead. Finally, this baby was given Tadalvidin prophylaxis for 4 weeks, start the first dose within the 12 hours according to Thai National Guideline 2020. And then we monitor her for adverse event of Tadalvidin, including anemia and neutropenia, and perform the HBV DNA PCR for early infant diagnosis. At the first month, the result revealed negative, but for the 4 months, it will happen in November 2020. So I think this is for the case. And thank you for your attention, and we are here to answer and address your comments and questions. Thank you.